Being part of investigations can be really scary as a nurse, a midwife, a doctor, or as a healthcare professional in general. But how are they looked at in the NHS? Now, within this, I'm going to use one of my own errors that I have made within my career, a medications error, and I'm going to tell you how it was very different when I qualified to what it is now in how they look at investigations. Why am I telling you this? Well, it helps to reassure any newly qualified midwives, nurses, doctors about how the process is taken these days, so that we have honesty and transparency when things don't go quite so well, to be able to talk through those processes, but also to provide some reassurance to those who come into healthcare services, how things are looked at when things don't go quite so well. And it is this change that has been one of the most significant changes I have experienced myself in my career, from where it used to just blame the individual, but now it's looking at the system as a whole, because when we learn as a system as a whole, we can start finding the root cause analysis, so the reason why, and often there's a multitude of reasons why. It's often the Swiss cheese model that is used in the human factors training aspect. And then we can actually start addressing all of those different systematic issues to reduce the chance of it occurring again in the future. And in telling you this, it is just opening up that we are imperfect humans working in imperfect systems, and we do sometimes make mistakes. It's about what we do after the mistake has happened, how we apologise, how we do that duty of candour, and how we learn as a system and help to reduce other people from making that same mistake. And it is in that learning, especially if you address those root causes, that actually improves safety for everybody entering the doors within healthcare systems across the world. So I'm going to give you a brief overview of the medication error that I personally made as a midwife. And then what I'm going to do is actually unpick how it would be looked at if the same mistake happened again today. So I was doing my drug round and I had checked the name, the date of birth, the prescription that was in the drug chart itself, checked the hospital number, checked for allergies, as you should do as standard. And I administered this blood thinning injection and taught them how to do it, because that's my normal practice, because I know that women and people will be going home with blood thinning injections to reduce the chance of blood clots happening. So I administered this, and as I was talking through and had given this and taught them how to do it, they said, "So am I going home on this twice a day then?" Now my heart sank at that point, because I was like, oh no, she shouldn't have had 2 doses. Where has the second dose come from? I've looked after this person all day. I've definitely not given her one before. And then looked thoroughly at the drug chart, and somewhere on the front of the notes, there had been a dose given much earlier than my shift. So what I did is I apologised. It was my mistake, my error. I said sorry. I then went and got a doctor to come and review, because there is a medication error that now needs a review. Do I need to do anything different? Do I need to do anything else? And then I did something called an incident report form. So what I did is I said that I've made a drug error, this is what happens, this is what was the follow-up, and this is how it's graded. And it's either no harm, near miss, for example. It could be low harm, it could be moderate harm, or it could be severe catastrophic. And at the time, I took absolute full responsibility. That is my registration, that is my mistake, I made that error. And at the time, we used to have an annual supervision of midwives. And so what I did is, after that mistake, is I wrote a long reflection, went back to all my medications, reports, guidelines as an NMC registrant. I wrote a very long reflective piece that was then taken forward at my supervision of midwives on an annual basis. It's a little similar to your reflective accounts as an NMC registrant nowadays. Now, at the time, it was very much blame the individual for making that mistake. There was very little system learning at the time that I had qualified. Now, the problem with this is, firstly, it doesn't open up honesty and transparency. It can actually breed people keeping things under the radar and not reporting things, because they feel like they are going to be held accountable, lose their registration. And what that does is that inhibits the learning aspect. What it also means is it doesn't actually try to find the root cause analysis of why that individual may have made a mistake in the first place. Deliberate harm is very, 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 very rare within healthcare settings. The majority of people come to work because they want to make a difference, they want to care, they want to make things better for people. Very, 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 very few people come in to deliberately harm people. And so what we've got to ask is, why do mistakes happen with people who genuinely want to make a difference, who genuinely want to care? And that's because there's often a myriad of different systems in place that have led and contributed to that outcome, otherwise known as the Swiss cheese effect. Now, if I had made that same mistake today, it would be looked at in a very different way. And this is why I want people to not be afraid of being able to come forward, to be open and honest and transparent in bringing things forward that have happened, and why going in and being open and honest and having things like huddles, for example, and debriefs, and going with your risk teams to be able to discuss things that have happened are really important to improving safety for everybody. It's nothing to fear, and actually the system can learn a huge amount from near misses, from no to low, moderate harm as well, like ways to make things better overall for everybody. I'm just going to caveat this by saying that this is a no to low harm event that has occurred. Now, the same principles are used to more severe catastrophic outcomes. However, there are often other systems that come into play at that stage in terms of investigation management. I'm focusing on the low to no harm because there was really low harm in this case. Thankfully, all was fine. So there's something called the SEEPS model, which you can easily and freely search for. And the SEEPS model looks at all the different aspects that contributed to that person making that mistake, that error, overlooking whatever it was, and that then leading to some sort of outcome. The SEEPS model looks at the individual person and their human factors, the tools and technology that is in use, the internal and external environment, and the organisational aspects. So firstly, as a midwife, I was newly qualified, so from an education and experience perspective, this absolutely can contribute to an increased chance of A, needing more support, B, needing more time to be able to undertake tasks which you don't necessarily have in reality. At the time, there was no retention programme either, so there wasn't anyone to work with. It was just you are chucked in the deep end after your 2 or 3 weeks of your supernumerary period, and that's that. As a newly qualified midwife, I was on my second rotation back to the wards. I had care of 10 families, and actually I discharged 3 that shift and had them replaced with 3. So overall, in a 12-hour shift, I'd looked after 13 families. The day before, I had been shouted at by a family because they were not discharged quick enough because of the workloads that I was under. We know that incivility can have consequences for everybody, for patients and for people themselves. And then I didn't actually get a break until about 5:30 that evening, and only took 20 minutes of my unpaid break, purely because my workload was too high to be able to manage that. So organisationally, there's a lot of things going on that can sometimes contribute to fatigue and also to mistakes happening. So then we look at the tools and technology. It was a paper chart that had handwriting on it. On the very front of the drug chart, there had been someone who had prescribed it as a one-off on the front because of the hours after birth that it needed to be given initially. But the person who had originally written the regular medication had put a certain time on the regular medication page. Now, as a midwife, what you tend to do is scan the front of the drug chart, scan all the single ones, but it looked very similar to another medication that had been given, and the legibility was not brilliant either. Now, whilst digital infrastructure isn't always perfect, firstly, it will be legible, what you can actually read. And the second thing is if you've recorded that you've given something, it actually stops someone because it comes up with warning messages for someone else giving that medication too soon if it's already been given. Organisationally, I was also on a row of 3 long days, which also contributes to fatigue and tiredness. And in hindsight, I should have split up my shifts more frequently. From another perspective, from tools and also tasks, as someone who's doing a medications round, you should wear a tabard saying please do not disturb. At the time that this was just not standard practice, this wasn't the case. But it meant that as I was doing the drugs and medication round, people would ask me for like infant feeding support. They would ask when they're going home. They would ask me other questions when I needed to be task focused and be able to do the medications as safely as possible for each individual person. The more interruptions you have, the more likely the mistakes are likely to happen. Now, what went well is I was signed off as competent to give medication, so from an educational perspective, it wasn't an educational aspect in this case, but it's something else that's factored in when looking at investigations. It's also looking at the policies and guidelines, and there were plenty of policies and guidelines going through how you check medications, how you check the wristband, how you make sure that you've got the right patient, the right medication, etc. as well. And that was followed. When looking at all of this does not detract the responsibility from the individual. I would still take that responsibility. It is still my mistake. It is still my error. I still hold my hands up, apologise. It's still something that I have done. I would still learn and write a reflection. I would still go back to the NMC side of things and revisit all of my drugs and medications policies. I would still look at my local trust guidelines as well and write that reflective statement as well. That more and more people could potentially make the same mistakes because of all the other aspects that were going on that led to the mistake happening in the first place. What learning from incidents does is it can provide evidence for business cases for more staff, for example, because if there's lots of errors happening in practice because the workloads are far too high, that gives you more evidence to go, actually, we need more members of staff because we need a much smaller patient to staff ratio overall. We look at the systems where we think about having tabards so that people don't disturb you, so that you're not interrupted in task-focused procedures, for example, with the exception of it being an emergency, for example. The day before, I had been verbally abused by a family because they weren't discharged quick enough because my workloads were far too high for any one person. That in itself meant that I had incident reported that in itself, but there was no follow-up support, there was nothing else. It was just one of those things. From a psychological aspect, that's not a great work environment to have worked in following verbal abuse either. The stress you feel and the fact that I knew that there was going to be a complaint after it because I couldn't get them discharged the moment that they wanted to be discharged amongst all my other 10 women and families, it was really, really stressful. Tools and technology, are there safer systems to be able to administer medications? You know, are there electronic systems that then have warnings and flag up that someone has had that medication before? Or if they're being re-prescribed something after someone has already prescribed it, they will flag up, is this a change to the medication? Do we need to remove the dose? Do we need to change the time, for example? So that whoever has prescribed it is unable to make the error where there is a duplication of medication somewhere along the lines, and then putting all the onus on the person who's administering it to 100% know that that person hasn't had it before. Also removes the aspect of error that can sometimes happen if things are ineligible or not completely clear as well. So think about the communication for that individual as well. After that event, what I learned to do is start asking people, have you had this before? Do you know what it is? Do you know what the risks, benefits and side effects are? It takes a bit longer, which when you are really busy with 10 to 12 families at a time in a shift is incredibly challenging. But from that perspective, it's enabled much more trust between myself but also the families, and that was a big learning thing as a newly qualified midwife, is to start asking, have you had this before? Do you know what it is? I've given some time to go, yes, actually I had this yesterday. Yep, I know what it is. Yes, I know what the risks and benefits are. I know why I'm being prescribed this. And what this also does is empowers that individual as well to know what they are taking, when they are taking it, and why they are taking it too. Also from an organisational perspective, if you are having lots of instances in one area, it helps you to provide business cases for what the pressures really are. We can all say that we're understaffed, we're overworked, we've got too high a workload going on. But when you start factoring in things like acuity apps, acuity tools, for example, you can really see on paper that there aren't enough care hours to meet the care needs of individuals and families, for example. And when you have things that are reported as near misses, for example, low to moderate harm, not only is it helping the system learn, but it's also providing evidence for managers, for senior leaders to be able to put business cases forward to start looking at what is a safe number of patients for a midwife to look after. Can we reduce harm by lowering the amount of pressure and workload on people so they can stop and think and have time with patients far more clearly too? All of this places the onus on the system for learning alongside the individual, and it means that we are not scapegoating individuals. We are learning all together. The individual still takes that responsibility. They are still the one that has individual learning to take forward overall. But the system also learns so that if I have another staff member in exactly the same situation, different day, that same individual should have things that help to reduce the chance of that mistake happening again. Therefore, reducing the chance of a mistake happening, therefore reducing the chance of harm and improving safety and outcomes for everybody who walks through healthcare system doors. It is in knowing how investigations have changed over time that gives me the reassurance that healthcare can change, that maternity services can improve, it can make things better overall when we start learning as a system and start finding the root cause analysis of lots of different things and making the root cause of things far better for people. I know it can happen with the right infrastructure, with the right outcomes, with the right recommendations in a maternity review, and with the right financial models of support too. I know it's possible because I've seen that difference that has happened over the last 13 to 14 years of my career. It's not going to happen overnight. It will take time. But actually, this is a really key learning that if we start learning as a system and we start finding the root cause of lots of different things, we can start addressing and putting real proper learning in place and reduce the chance of harm occurring overall. For anyone who's been part of any of this, you should also be provided with some support after as well, usually through things like PMA, for example. Human beings are imperfect and they work in imperfect systems. It's about that learning from a system perspective, but also an individual perspective, and that's how we reduce the incidents happening within the NHS, but also how improvements in safety happen as well.